In this lecture, we're going to talk about altitude illness. So what we want to cover is just the brief basic initial physiology and the normal human responses and adaptation to altitude. We'll start talking about various types and degrees of altitude illness, some strategies for prevention, and then treatment recommendations. So here's a scenario. So we have a 56-year-old climber on Mount Rainier who arrived from sea level earlier in that day. He has a rapid ascent up to Ingram Flats and develops a headache, nausea, vomiting, and fatigue. So what's causing his symptoms and how should we treat him? So let's first of all talk about some basic terminology. So in terms of altitude, so we can start at the bottom. So we have low altitude, or just 0 feet, all the way up to 5,000. And then medium altitude starts between 5,000 to 8,000 feet. High altitude then is between 8,000 to 12,000 feet. Very high altitude is 12,000 to 18,000 feet. And then we really have this kind of then degree of extreme altitude between 18,000 and 29,000 feet. So here locally in Washington, Mount Rainier, we consider to be in the category of very high altitude. Most people will start to have symptoms, around 8,000 feet plus or minus 8 to 10,000 feet, so kind of in that high to very high altitude range. So one of the first things that happens on the ascent to altitude is changes in your breathing. What happens is the body senses that you have less oxygen than you're used to. And what you do is something called the hypoxic ventilatory response. And what you do is you increase your respiratory rate to try to increase the amount of oxygen that your lung is getting. So what we can see here is in this graph, the atmospheric oxygen content at altitude is significantly lower than it is at sea level. So at sea level, the partial pressure of oxygen is significantly higher. It's about 160 millimeters of mercury, which is 21% of atmospheric pressure of 760 millimeters of mercury. And then up at the summit of Mount Everest, we end up having a partial pressure of oxygen of 53%. So that's almost a third of the amount of available total oxygen that we have at sea level. So what happens is with altitude, we can see that the amount of oxygen that we're inspiring is significantly less. So I mean, if we look the difference between Denver and a ski resort, on the top of Mount Everest, and even what you would have in a commercial aircraft, the higher you go, the significantly lower the barometric pressure, the significantly lower inspired amount of oxygen that you have. We also see some cardiac changes. So in order to try to get more oxygen to circulate around to your blood, we have an increased heart rate and increased blood pressure. The heart starts pumping harder per beat. And then we also move blood to our heart and our lungs and our brain to try to focus attention on all those vital organs. And then over time, as our body gets better and more adept at utilizing that oxygen, this stabilizes with acclimatization. So if we look here at this graph, in terms of altitude, sea level, and then on ascent to altitude, we see an increase on average resting heart rate in these participants. Next is blood changes. So a couple of changes happen in other parts of the body. So the kidneys release a hormone that called erythropoietin that forces the body to make new red blood cells. The more red blood cells you have, the more ability you have to compartmentalize and to transport oxygen around to your body. And this can increase by about 30%, and it increases the oxygen carrying capacity of your body. If we look at this graph, this is an article from the Journal of Physiology and Pharmacology. So somebody at altitude, looking at from 0 to 40 days of time at altitude, looking at the percentage increase in their hematocrit, and the hematocrit is a way of measuring the volume of oxygen carrying red blood cells in the body, and it goes up exponentially with ascent to altitude. We also have a way of compensating for the acid base in our body. So as we increase our breathing, we blow carbon dioxide off. So we breathe air and rich in oxygen in, and we blow off carbon dioxide. As we blow off carbon dioxide, our blood ends up with not enough carbon dioxide in it. And what that is coming from is another chemical compound called bicarbonate. So in the middle on this graph on our right, we can see there's this constant ebb and flow in this equation of how carbon dioxide combines with water to create bicarbonate, which then turns into a proton or a hydrogen ion or acid, and then we urinate out bicarbonate. So if we are blowing off too much carbon dioxide, the whole equation shifts to the left here, and we end up with not enough acid in our blood, and we end up with too high of a pH, or what we call a metabolic alkalosis. So what we end up having to do is our kidneys have to get rid of extra bicarbonate on the right side of that graph in order to try to balance this out. And while this is probably too much physiology for most people, where this becomes relevant is this is how the medication acetazolamide or Diamox works. So Diamox works by excreting and getting rid of bicarbonate. It's a bicarbonate diuretic, and by getting rid of that bicarbonate, you create an environment where it balances this equation out earlier, and you don't get a lot of the side effects of altitude by blowing off too much carbon dioxide, which allows you to breathe more rapidly and get more oxygen in without having the side effects of blowing off too much carbon dioxide. So acute mountain sickness. So almost 50% of people will get sick at high altitude. Remember, that's above 8,000 feet. And it's a constellation of symptoms including headache, fatigue, nausea, and sleep disturbances. And this will start really within a few hours, and these symptoms will usually peak at 1 to 2 days. So we can help stratify people in terms of risk. How likely are they to get acute mountain sickness? So patients who are at lower risk are people who have no prior history of acute mountain sickness that are going to be ascending to less than 2,800 meters or 9,000 feet. They're going to take greater than 2 days to arrive at that altitude, and they're going to be sleeping at less than 500 meters per day, higher than where they were the previous day, and they're going to take a rest day every 1,000 meters. So this is a very conservative, very low risk acclimatization schedule. Patients who are going to be at moderate risk are people who have had a history of acute mountain sickness. They're going to be ascending to 2,500 to 3,000 meters in a day. Remember, Rainier is about 4,392 meters. They might have no prior history of acute mountain sickness, but they're going to be climbing to greater than 2,800 meters in a day, or they're going to be ascending greater than 500 meters a day at elevations above 3,000 meters, but will have a rest day every 1,000 meters. And the patients who are at high risk for this are people who have a history of acute mountain sickness ascending to greater than 2,800 meters in a day, prior history of high altitude cerebral edema, going greater than 3,500 meters in 1 day, or they're going to be ascending more than 500 meters a day above 3,000 meters without rest days, or a very rapid ascent. So altitude illness, how do we treat it? So the most important thing you can do is descend. Keep going down 1 to 3,000 meters until somebody's symptoms resolve. This can almost spontaneously resolve most of the symptoms of acute mountain sickness. You can also give supplemental oxygen to keep the partial pressure of oxygen greater than 90% saturation, or you can increase the oxygen content by increasing the pressure around the person and simulating being closer to sea level with a hyperbaric chamber, portable hyperbaric chamber called a Gamow bag in this picture. So we can also use acetazolamide. Remember, acetazolamide is a bicarbonate diuretic that helps rebalance this equation caused by blowing off too much carbon dioxide. We give 250 milligrams twice a day. We don't want to give this in people with liver disease or cirrhosis, severe kidney disease, and it has a similar structure to sulfa-style antibiotics, so we don't want to give it to patients with sulfa antibiotics. And it can cause a weird taste change, especially with carbonated beverages, and it can cause fatigue, nausea, and vomiting, and also tingling around the lips, the face, the tongue, and the hands. Now that's not dangerous, but it is kind of noxious and can cause some unsettling to patients if they're not aware of it ahead of time. So for severe altitude illness, we can also treat with a steroid medication called dexamethasone. We give this initially as 8 milligrams. It can be orally or injected or in an IV. And then we give 4 milligrams every 6 hours. And there's very few side effects or contraindications to healthy populations that are going to be mountaineering. We can also give symptomatic care, ibuprofen, 400 milligrams 3 times a day or every 8 hours. An anti-nausea medication called ondansetron or Zofran, 8 milligrams, either intravenously or orally every 8 hours, and oral rehydration, and then also prevent hypothermia. And all of these treatments we have available in our advanced life support cache. So approaches to acute mountain sickness and high altitude cerebral edema. So first of all is stop ascending immediately. And for mild to moderate symptoms, you can maintain altitude and hydrate and try acetazolamide and provide symptomatic care. And then when symptoms clear, try ascending more. For more moderate to severe symptoms, however, it's really important to not only descend, but also preemptively treat with acetazolamide and symptomatic care. If patients are having evidence of high altitude cerebral edema, however, which is confusion, altered mental status, or an abnormal balance or gait, then they should have immediate and rapid descent or treatment with a gamma bag, acetazolamide, and dexamethasone and supplemental oxygen. So there's also a condition called high altitude pulmonary edema, and this is caused with fluid buildup in the lung because of the changes in the ambient pressure compared to what people are used to. And this can lead to a decreased diffusion of oxygen across the lungs and lead to a condition of too low of oxygenation in the body called hypoxia. And the lungs fill up with fluid and it impairs oxygen exchange. This can then cause fatigue, shortness of breath. When you listen to the lungs with a stethoscope, you'll hear crackles in the lungs. So we diagnose high altitude pulmonary edema by having at least two of these symptoms: shortness of breath or dyspnea rest, cough, weakness or fatigue, chest tightness or congestion, and then at least two signs: crackles or wheezes in the lungs, blueness or central cyanosis, breathing too fast, tachypnea, or having a fast heart rate, tachycardia. And we treat this by descending as well. Notice a trend here: supplemental oxygen and acetazolamide. And there are some additional therapies that can be administered by a physician. A medication, calcium channel blocker called nifedipine, 30 milligrams every 12 hours. Sildenafil, which is Viagra, which is a phosphodiesterase inhibitor, and then also dexamethasone. So key points are acclimatization, if able, can help prevent a lot of these symptoms and conditions. It's important to recognize the signs and symptoms of altitude illness early. The best therapy in all of these conditions is rapid descent. Medications can be helpful, and importantly, don't forget hydration and prevention of hypothermia.